Hello, this is Lauren Trito, and this is my Pathophysiology of Sepsis. Starting with the history of present illness, the patient was in 3228. She's a 74-year-old Caucasian female. She came into Chesapeake Regional Hospital on September 5th after she was recently just at Norfolk General Hospital for a UTI and spleen infarction. She never fully recovered from this and has been experiencing generalized weakness and vomiting. She was experiencing tachycardia and leukocytosis in the emergency department. She has a history of lung cancer, which they just found at Norfolk General when she was there, and she's refusing treatment for it. In the emergency department, she received 1 liter of intravenous fluid, and she was admitted to the floor on September 6th. Moving on to the admitting diagnosis. This patient's admitting diagnosis was sepsis, and sepsis is characterized by a serious condition of which the body responds inappropriately to an infection. This negatively affects the organs since this process turns on the body. Sepsis disturbs the immunological balance between inflammation and anti-inflammatory systems in many ways. As a result of these pro- and anti-inflammatory pathways being used, cytokine mediators and pathogen-related molecules are being released systemically. This leads to a coagulation and complement cascade. The first sign of sepsis is when either pathogen-derived molecular patterns like exotoxins or endogenous host-derived danger signals are seen. These molecules trigger certain receptors such as toll-like receptors on the surfaces of antigen-presenting cells and monocytes. Symptoms of sepsis are able to be seen by this point due to the transcription of genes during the inflammation, cell metabolism, and adaptive immunity. While both pro- and anti-inflammatory pathways are stimulated, the inflammation aids in progressive tissue damage, ultimately causing multiple organs to dysfunction. Within the body's innate immunity, many neutrophils come together to create a major line of defense to fight off pathogens. This is the body's first resource it uses. Both mature and immature neutrophils are forced to be released in severe bacterial infections. They are taken from the bone marrow via emergency granulocyte maturation. Either pathogen-derived molecular patterns or endogenous host-derived danger signals will activate these neutrophils, but this causes the immature neutrophils to not have their full capacity of phagocytosis. Okay, moving on to comorbidities. Comorbidities that this patient has is acute kidney injury, urinary tract infection, dehydration, squamous cell lung cancer, type 2 diabetes, hypertension, and I also do want to add that this patient does smoke, and she has a history of it. So we'll dive into acute kidney injury. She was also diagnosed with this on the submission. An acute kidney injury is a sudden and irreversible decrease in the kidney's ability to function. When the kidneys have been exposed to ischemia or even direct toxins, it ultimately leads to cellular insult and acute tubular necrosis. The brush border thins out, cells that the kidneys rely on are killed off, and tubular cell function is hindered as well. One intrarenal cause of this injury to the kidneys can be due to mechanisms behind glomerular nephritis or acute interstitial nephritis. These mechanisms are caused by immune-mediated injuries of the kidney vasculature, inflammatory responses, and immature immune complex depositions, leading to glomerular and tubular damage. The next comorbidity that we will dive into is urinary tract infection, which she just had at her last hospital admission. A UTI is when the bladder and its associated structures become infected by a bacteria. Pathogenic bacteria go up from the perineum and rectum into the periurethral space. Women have a higher risk of developing UTIs due to their short urethras. E. coli is the bacteria responsible for most UTIs. When the bacteria ascends into the bladder, it invades the bladder mucosal wall, causing an inflammatory reaction known as cystitis. Urine has natural antimicrobial properties and elements to prevent infections like this, but the bacteria that causes UTIs have adhesions on their surfaces which let other organisms latch onto the urothelial mucosal surface. Pathogenic bacteria also develop mechanisms in order to survive hyperosmolality. Many are able to break down urea into alkaline ammonia in order to increase urinary pH. UTIs are also common after kidney transplants with immunosuppressive drugs. This can lead to the development of resistant bacterial strands. Moving on to risk factors that this patient has, which may have led her to develop this case of sepsis, is that she is over the age of 65. She has conditions such as diabetes and cancer. She has a weakened immune system due to a kidney transplant, and that she takes immunosuppressive drugs for. Being exposed to a hospital environment and having a urinary catheter. Physical assessment findings for this patient during the shift were that she was alert and oriented ×4. She was uncomfortable due to her IV, but she was still kind and pleasant. S1 and S2 heart sounds were heard, and she had a regular rate and rhythm. She had bilateral radial and pedal pulses that were +2. They were weak, but they were still palpable. Her capillary refill was under 3 seconds, and she had no edema. She did have clear lung sounds and no accessory work of breathing. Her O2 stat was 98. She had active bowel sounds, and her abdomen was soft and non-distended. She had her catheter taken out, so she was using a PureWick, and her urine was yellow in appearance. She had a strong grip and purposeful movements in all of her extremities, but I was unable to assess her gait because the nurses did not want her walking due to her high falls risk from having toe amputations and just being weak. Her IV was patent and dry. A diagnostic used was a chest x-ray. This verified her large lung mass and found her to have cardiomegaly as well. Some abnormal lab values for this patient was her white blood cells were high, and this was due to her infection and sepsis. The white blood cells were rising in order to fight off the pathogens. Her red blood cells were low due to her chronic anemia, and this could be due to the fact that she takes immunosuppressive drugs from her kidney transplant. Her sodium levels were low, and this could be due to her acute kidney injury and fluid imbalance from her dehydration. Her glucose was high, and this is because she has diabetes, but it's also because in sepsis, insulin resistance is caused, and there's an increase in glucose production from the increase of pro-inflammatory cytokines that are being used in sepsis. Her total protein and albumin were low, and this was due to her acute kidney injury. Her kidneys are just not filtering as they should be, and those are just either being broken down or lost in urine. Moving on to vital signs from the shifts, her blood pressure ranged from 96/71 to 163/77. Her temperature ranged from 96 to 97.3. Her heart rate from 66 to 79. Respiratory rate 12 to 26. And her oxygen was from 94 to 98. Medications that this patient takes is cyclosporine. She takes 25 milligrams of this 2 times a day. This is an antiviral for her kidney transplant. This next drug, she takes 180 milligrams twice a day. This is her immunosuppressive drug for her kidney transplant. She also takes prednisone, 5 milligrams a day. This is an anti-inflammatory for her organ transplant. And fluconazole, 200 milligrams every 24 hours for her sepsis and UTI prophylaxis. The top nursing diagnosis that I chose was ineffective peripheral tissue perfusion related to arterial or venous blood flow exchange problems. Cues that led me to this decision was that the patient has developed systemic inflammatory response syndrome. She has peripheral artery disease, stenosis, and limited gait. The first goal that I chose was that the patient will demonstrate adequate tissue perfusion as shown by palpable peripheral pulses. The nurse will help with exercises and movements such as walking. The nurse will also keep the patient warm and have them wear clean all cotton socks or round toe shoes. Goal number 2 is that the patient will understand changes needed to be made in order to increase tissue perfusion. The nurse will teach the importance of smoking cessation and teach the importance of good glycemic control. The treatment plan for this patient is that the staff was finding out the specific cause of her sepsis since it was unknown. She is receiving IV fluids for her dehydration in the meantime, and she has oxygen ordered if her O2 stat goes under 90. Her physical therapist and nephrologist were consulted, and she has H&H checks every 6 hours, because if it reaches below 7, then they're going to do a transfusion. Financial considerations for this patient. I chose this immunosuppressive drug that she has to take for her kidney transplant because it costs $147 for 500 milligrams. This patient is prescribed to take 180 milligrams twice a day, which is 360 milligrams, and that costs $105.84 a day. So that seems to be a lot and can definitely add up, but this is a necessity for her since she had that organ transplant. My post-shift evaluation was that the patient is still in her hospitalization stage of her admission. The specific reasoning behind her sepsis was still unknown, so the staff was trying to pinpoint it to come up with the best treatment option for her. She is being treated for her dehydration and acute kidney injury in the meantime. Her physical therapist and nephrologist were consulted, and she is being taught treatment options for her lung cancer. And these are my references. Thank you for watching.